So thanks everybody for participating in Medical Grand Rounds. Before we go further, I'd like to acknowledge that McGill University sits on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks the territory on which peoples of the world now gather. So I'd like to introduce our two speakers. Evan Weber is a certified genetic counselor with a dual role at the MUHC. He's both a laboratory genetic counselor at the core molecular diagnostics lab and a clinical genetics counselor at the Hereditary Cancer Clinic. He has a special interest in service delivery models for hereditary cancer genetic testing, which will be the topic of today, and the psychosocial implications of cancer genetics. Dr. Folks, the ever humble Dr. Folks, his bio says he's a medical geneticist, but he's a little bit more than that. He's our Division Director of Medical Genetics. He's the chair of Human Genetics at McGill. Dr. Folks has supervised over 70 graduate students and other types of trainees in his career. He has over 700 publications with an H-index over 100. He's a fellow of the Canadian Academy of Health Sciences, the Royal College of Physicians of London, the Royal Society of Canada. He received in 2022 the Chu Wei Memorial Prize in Cancer Research from the University of British Columbia, and is a recipient of the Prix Wilder Penfield, one of the highest scientific honors in Quebec. So thrilled and honored to have both of you speak today to us on Tales from Mainstreaming Cancer Susceptibility, if I can say that word, gene testing at the MUHC.
Thank you, Mark, for the generous introduction. So, yeah, this is a double act between myself and Evan Weber, and just to point out that everything we do is in concert with the genetic counselors. Laura Palmer's off skiing, so Evan is got the short straw giving the talk. Right, so now we need to move the slides on. Thank you. Use this one. I don't have any disclosures. Evan has received some honoraria from Merck and AstraZeneca. So, December 2022, I gave a talk at Grand Rounds, talking about how we got to where we are now, talking about the major genes for breast and ovarian cancer, how it had taken essentially, from the time of the discovery in 1994, 95, taken us 30 years really to get to the point where we had an established set of breast and ovarian cancer genes. And so we thought it was time to introduce mainstreaming testing, that is testing directly by the treating physicians rather than through genetics. And what we're going to be talking about now essentially is 6 years of mainstreaming for ovarian cancer, which Evan's going to focus on. And he's going to also talk about 5 months of mainstreaming for breast cancer. And I'm going to tell you a little bit about some of the studies we did beforehand to get to that point. So the objectives from this presentation are to show how cross-collaborations can increase access to genetic testing, reduce patient waiting times, and allow healthcare professionals to practice at the top of their scope and to foster positive relations between clinical services, not only to obviously to benefit patient care, but benefit research opportunities, which I'll tell you about. So this was the talk I gave in December 2022, which was focusing on what should we test, who should we test, who should do the test, and who should follow up on the results. And this was given by myself and Jean-Baptiste, who at the time was heading the germline part of the lab, and now headed by Leora Witkowski. And I'll come on, Evan will mention their work later. So just to recap, which common cancers have a substantial contribution from Mendelian factors? Obviously, you don't want to focus on cancers that don't have a substantial contribution. Well, just crudely put, it's about 5 to 10% for breast cancer, 20 to 30 for ovarian cancer, 5 to 10 for colorectal cancer, 5 to 15% for pancreas cancer, and metastatic prostate cancer is about 10 to 15%. So these are, not insignificant numbers because these are all common cancers. I mean, these actually, if you take out lung cancer, then these are the top cancers, both in terms of incidence and mortality in Canada and in the United States. So this is a substantial number of people. ovarian cancer affects 2,500 women at least a year in Canada. And the 10 genes that we came up with, or the groups have come up with after all this work, are shown here, and the color code is to tell you how they're all a little bit different. They all predispose to breast and or ovarian cancer, but they have the flavors shown here indicate they have slightly different properties. And I won't go through all of them, but just to make the point that, for example, RAD51C and D have a moderately increased risk for ER-negative breast cancer only, not ER-positive breast cancer, and a moderate risk for ovarian cancer, whereas P53, for example, has a very high risk for breast cancer and, in fact, a high risk for multiple cancer types. So these genes are all a little bit different, but together they cover, if you ran this panel, you could argue about including a few other genes like CDH1, but if you ran this panel, you would find 95% of the Mendelian susceptibility to breast and ovarian cancer. When you come to colon cancer, there's a beautiful slide from my colleague Laura Valesco in Idabel in Barcelona. Essentially, you can see along the bottom, you can split it into non-polyposis and polyposis types of colon cancer, and you can see that all the genes are written out on the bottom. So this is really the established list of genes, and there are a few new genes that are coming through now, very rare, like MBT4, but they don't really contribute very much. You have to screen a lot of people to find one case, whereas things like the Lynch syndrome genes are also important for ovarian cancer, and so we need to make sure our panels include these genes. So mainstreaming is a word that was first used by Nazanin Rahman about 10 years ago in an article in the Journal of the Royal College of Physicians of London, when she was talking about the idea that genetic testing had to be moved out from the genetics clinic into the oncology clinic. And it was first really trialed at the Royal Marsden for ovarian cancer at that time. Universal genetic testing is a bit a different concept. That is essentially that you test everybody. So mainstreaming doesn't say who you test, but it says who does the testing. That is done by the primary physician. Universal genetic testing doesn't say who orders the test, but it essentially means we test pretty much every person with that particular diagnosis. And the landscape obviously has changed over the last several years from the traditional model, which is shown here: referral, pre-test genetic counseling via genetic counselor like Evan, genetic test results via a genetics healthcare professional, the result, post-test counseling. So these 5 steps, and each of these steps, there's a risk that the patient may not continue through. And there's significant delays. This whole process used to take us an average of 2 years before we had multi-gene testing, for example. And using ovarian cancer as an example, we know that between 2014 and 2017, at this hospital, only 50% of patients with high-grade serous cancer referred to genetics, even though it was thought to be a good idea for quite some time that these patients should be referred. There wasn't really a pipeline, and they had to wait a long time. As I say, it was down to 6 months by 2014 to 17, but still, quite a long delay, which again meant, unfortunately, with the seriousness of ovarian cancer, some of the patients actually died before they were seen. And so, can we move this? As I mentioned, there's this concept called mainstreaming, where you don't have direct contact with genetic counselors. The tests ordered by the treating MD, and the results provided by the treating MD, genetics team, or both. Those with negative results are not generally seen by genetics unless there's a very strong reason to be seen, strong family history not explained by the genetics or other factors or other uncertainty about the result. And those with positive results are sent to genetics for counseling and cascade testing. And as I mentioned, this was first tried at the Royal Marsden Hospital in Fulham Road in London and was very successful. So this is the traditional model, as you say, and this is you basically cut out the early part of the process, and the result is provided usually by the treating physician, and then patients are, in certain models, are referred to genetics. Sometimes they're not. It depends on the particular flavor of mainstream, but this is the basic principle. Universal testing for breast cancer, as I say, is a little bit different. So we received the funding from the Quebec Breast Cancer Foundation and the JGH Foundation to undertake a study where we'd offer testing for the 3 most important ones, BRCA1, BRCA2, and PALB2, to all adult women affected with the first primary invasive breast cancer in Rosse Network Hospitals, so the three hospitals, St Mary's, the JGH, and the MUHC, with an option to extend the testing to these 14 other genes, some of the genes that I mentioned on that top 10 list, with a proven or postulated relationship. So we didn't opt for exactly the mainstream model. We actually had a genetic counselor and an assistant who met with all the patients, obtained the consent, arranged for blood to obtain results and counsel women. And this was a modification because we didn't feel that we were ready to jump straight to mainstream. We wanted to sort of see how this went as a first model. There are other reasons why we did it this way, but it was all the genetic testing was done at the JGH by George Chong. So it meant there was a more centralized genetic testing of all patients. And the project ran 2019 to 2022. As you can see from the dates, very unfortunate timing. We started and COVID kind of hit us. So it meant it was quite challenging to complete all the things we wanted to do. But this is I'm going to give you some results from the study now. So here's the plan: referral from your MD, contact by genetic counselor, consultation with the counselor, genetic testing, and then the result will be provided to you by the genetic counselor, and all the positives received by myself as well. The negatives got a phone call, and every patient had a chart note made at the MUHC and the JGH. And the results, we wanted to do it in 2 to 7 weeks, but of course we didn't quite hit that target, but actually not too bad when you think of COVID. So any female over age 18 with the first diagnosis of invasive breast cancer, BCIS and recurrent breast cancers were excluded. We after a while we realized, I mean, just because the number of to run this study on a slight sort of not exactly a shoestring budget, but on a relatively light budget, meant that we were having trouble keeping up with all the elements of the study. So we looked at the results after about 18 months and said, look, people over 70 often don't even turn up to the appointment. So they're not that interested. And when they do turn up, the mutation rates are extremely low. So maybe we're wasting our time, including women over 70 at diagnosis. But we did recognize that triple negative breast cancer is a special case because even older women with triple negative breast cancer can have germline mutations. So we said, okay, if you're over 70, you're not in the study anymore unless it's triple negative breast cancer. And so this is the result of the study. 1,000 women were ascertained, 729 were actually tested. About 80% had a negative test, about 14% had a VUS. We weren't quite sure what the variant meant. Most of them are very likely to be benign, but we weren't sure. And about 7.5% had a genetic variant of importance. There were 39 variants seen in the 3 genes that we call B1, B2, P2, so BRCA1, BRCA2, PALB2, and 2.1% in the other genes. So actually not a huge number of variants found. Just to show you here, interestingly, about 1/3 of the people we found mutation didn't actually fit criteria and wouldn't have been necessarily seen, and 85% on the secondary panel didn't meet criteria, which isn't surprising since the criteria were designed to identify high-risk persons, not low-risk persons, which generally the secondary panel is detecting. So you can see here, this is, again, the 3 main genes are the 3 main genes because they account for nearly all the variants. And the critical point is that these 2 in particular, there are therapies which are effective for these patients, and Evan will talk about that in a minute. For PALB2, I think there will be effective therapies, because essentially it works in the same pathway and binds. PALB2 stands for partner and localizer of BRCA2, so it gives you a bit of a clue what it does. It was identified by David Livingstone, and in 2007, our group at the Jewish and the MUHC were one of the groups that identified PALB2 as a breast cancer susceptibility gene. So as you see, 3/4 of the variants were actually in these important genes. So what were the predictors of actually having one of these variants in these 3 important genes? Well, not surprisingly, being young. So women diagnosed under 40 had a nearly 7-fold increased risk of having a variant in one of these genes compared with the reference group of 50 to 59. So you can see that obviously aiming at young women is a highly effective way of detecting most of the gene carriers. Although interestingly, even amongst every patient, if you just took all patients with a grade 3 breast cancer, it was still 12%. So that's at all ages. Obviously, will be lower at older ages, but overall, even just saying we'll just test anybody with a grade 3 cancer, that wouldn't be a bad criteria. In fact, you wouldn't miss that many people. And it's even more true for TNBC, which I mentioned earlier, triple negative breast cancer, which is strongly associated with BRCA1, 2, PALB2. You can see here a 20% frequency and a relative risk of odds ratio of 3.2. Interestingly, and importantly, the MHC and the JGH and St Mary's serve a very diverse group of individuals from all parts of the world. And so we're picking up people from Southeast Asia, from the Middle East, particularly with the French-speaking population, but 66% are of so-called European origin, which is actually relatively low for a sort of a study like this. In many centers in the US, it'll be 80–90% will be so-called white, but you can see the frequency of variance doesn't really differ. Some of these numbers look different, but they're very small numbers, but overall we're getting the same frequency. One perhaps surprising finding was that some of you may know that in the Jewish population, 1 in 40 persons at birth will carry an important pathogenic variant in BRCA1 and BRCA2, which is about twice or 3 times as high as seen in non-Jewish populations, but the frequency of mutations was no higher. So you can say, well, why is that? Well, I'd like to think that the reason is because we've been doing this for 30 years now, and the Jewish population of Montreal have become somewhat acclimatized to genetic testing, and many of them have taken the appropriate preventive actions so that we're not seeing them now as getting breast cancer. I mean, there are other explanations, but it is rather interesting that the frequency was, we would expect this to be 10% or more, and it's only 5.7%, which is not different from any other group. So I'm going to stop here, hand over the microphone, as it were, and let him continue with a story that is really more about ovarian cancer.
Great. Well, thank you so much, Dr. Fowlkes. I'm going to take over here. Dr. Fowlkes spent the last little bit talking about an embedded genetic counseling model, which is great if you have the human power to actually staff oncology clinics with genetic counselors, but that's not the reality at our center and in many centers. So I'll be talking to you today about mainstreaming, which is what we've sort of been implementing over the past little bit. So the story starts about 10 years ago, and I like to start with an example always. So this is a patient who's a 73-year-old female diagnosed with a high-grade serous ovarian cancer. As you can see, she was previously well and has a large family, including 4 children, 3 siblings, many aunts and uncles, and the family history is completely non-contributory for cancer. So historically, this would not be a patient that would be seen in the medical genetics clinic, given the fact that she was not diagnosed at a young age and she has no family history of cancer. I'll be coming back to this case later. So just to go back to some basic here, what is the goal of the hereditary cancer clinic? And I like to think about it in 3 different components here. Number 1 is, for a patient who's diagnosed with cancer at a young age or has a strong family history of cancer, identifying the cause for a cancer in the family could be quite strong for someone, can provide them some answers, provide them with some perceived control over a very destabilizing situation. So the idea of identifying the cause can be very powerful, even if there isn't any, actionability. But thankfully, there is actionability, because if we find that there is a hereditary cancer syndrome, this can help us assess the risk for future primary cancers, be that a contralateral breast cancer in someone with breast cancer, be that ovarian cancer. But of course, it also can help assess the risk for other people in the family, breast cancer and ovarian cancer in sisters and daughters, but also in the men in the family, prostate cancer, for example, male breast cancer, pancreas cancer. So historically, this is the goal of the hereditary cancer clinic, but things really started to change about 10 years ago when one of the major indications for genetic testing and referrals to our clinic is treatment planning. And this is always something we had to deal with. We often had requests of, a patient with early onset breast cancer, please offer testing quickly so that we can determine surgical planning. Do we need to go for a more conservative surgery, or should we think about perhaps, at the same time, contralateral prophylactic mastectomy on the other side to reduce the risk for second primary breast cancer? But really, it's PARP inhibitors that really changed the game for us. So this is one of the big landmark papers that came out about 10 years ago in The Lancet, where they looked at olaparib. And olaparib is a PARP inhibitor, which is a targeted therapy for individuals with BRCA1 and BRCA2 pathogenic variants, and is associated with increased progression-free survival for patients with these mutations. So in this paper, they looked at individuals with platinum-sensitive relapsed serous ovarian cancer, and they looked at it at individuals with BRCA pathogenic variants. And as you can see from this curve here, the lower curve here is individuals with BRCA mutations taking the placebo, and the upper curve here is individuals taking olaparib. And you can clearly see this curve is associated with increased progression-free survival among patients who are taking olaparib with a BRCA mutation. So the hypothesis basically from this paper was proven, and it supports the hypothesis that patients with platinum-sensitive recurrent serous ovarian cancer with a BRCA mutation could benefit from this drug. And this quickly led to Health Canada approving olaparib for these patients with BRCA pathogenic variants. So this obviously led to an influx of pressure from patients, from clinicians to improve access to patients with ovarian cancer for genetic testing. And the Gynecological Society of Canada put together a position statement in 2017 called No Woman Left Behind towards a pan-Canadian strategy for universal BRCA testing in ovarian cancer. And this was a call to action across Canada, basically saying that we should be offering genetic testing broadly to all patients with ovarian cancer such that they can benefit from treatment if they do test positive for a pathogenic variant. Things move pretty quickly after this. So of course, this is ovarian cancer, but PARP inhibitors were quickly being approved for other tumor sites as well. So for example, olaparib was approved for metastatic breast cancer in individuals with BRCA mutation. Other PARP inhibitors such as talazoparib was approved for advanced breast cancer and BRCA, but not just other cancers, but things were getting approved earlier in the treatment process. So rather than just recurrent ovarian cancer, individuals with newly diagnosed advanced ovarian cancer could benefit from olaparib. Of course, moving further, it was approved as well for pancreatic cancer with BRCA mutations, metastatic castration-resistant prostate cancer. Suddenly, we're dealing with many, many tumor sites that could benefit from genetic testing. We were not typically seeing many of these patients in our clinic prior to the approval of these drugs. And not just that, we have to see them faster. And with our very, very tiny team here at the MUHC, we were left with the question, what can we do? We just did not have the capacity to do this. So we brainstormed and we thought about how can we approach the situation where we have many, many patients who need to be seen and need to be seen fast. And our local response was to consider mainstreaming. So why mainstreaming at the MUHC? So again, limited genetics resources. We are a team of 2 genetic counselors and 1 to 2 medical geneticists, and we receive many, many referrals per week. We service many, many regions of Quebec. We have very long wait times, and that's obviously is not consistent or compatible with a situation where patients need testing quickly. We wanted to improve access. So again, if you think back to the earlier slide, we were only testing 50% of patients with ovarian cancer, and we need to see these patients faster. So we wanted to guide treatment and surgical decision-making as much as we could. We also wanted to ensure that we're offering testing on an equitable manner and offering testing to people irrespective of provider and postal code. We don't want to make sure that it's only the patients who happen to live in a city with a university health center that are getting testing. We want to make sure that we can do this as broadly as possible, such that no woman or man is left behind. And what was really important is having strong buy-in from all stakeholders, and that's what leads to success. And this is really the key point here, and this is what led us to partner up with the Gynecological Clinic here at the MUHC to really get this going, primarily due to the fact that ovarian cancer was the first tumor site to be approved for PARP inhibitor therapy, but also just given the fact that the Gynecological team here is extremely collaborative. We wanted patients to be seen faster. They wanted patients to be seen faster. They wanted patients to be tested. We wanted patients to be tested. And we thought that would be a really good opportunity to work together to get this going. So in 2017, we launched GeoIGT, Gyne-Onc Initiated Genetic Testing, and we wanted to make it as simple as possible. As Dr. Gilbert once told me, we wanted to make it idiot-proof, to make it as simple as we can. So we had one simple indication, high-grade, non-mucinous epithelial tubo-ovarian cancer, primarily high-grade serous ovarian cancer. If they check that box, they're in. If they don't check that box, we can discuss otherwise. So again, we launched this in August 2017, so going on almost 7 years ago at this point. And initially, we were doing an 8 to 14 gene germline genetic testing panel at an out-of-province commercial laboratory. But as of October 22nd, 2022, we actually moved testing to the MUHC. It was repatriated here, which made the process a lot simpler, and we offer 31 gene in-house panel. So again, the big change here is that genetic testing now is not ordered by geneticists or genetic counselors. It's ordered by gynecological oncologists. And initially, we had a protocol because we wanted to sort of ease our way into it, where all the results were coming to both genetics and oncology at the same time, and all results were being disclosed by genetics, primarily myself. But in October 2022, after a very successful 5 years, we felt that it was appropriate for Gyne-Onc to disclose all the results to the patients and refer the positives and the VUS as the variants of uncertain significance to genetics, and any other patient who feels that they could benefit from genetic counseling could also be referred as well. So again, what we did is we actually published a paper where we looked at what we call the pre-GeoIGT period, which was a 3-year period where we were able to see, how many patients with ovarian cancer were we testing and how fast. And we compared this to year one of GOIGT. So again, going back to earlier, we were testing 50.9% of patients with ovarian cancer. This is actually quite a bit better than the Canadian average, which was more closer to 20 to 30% at that time. But after 1 year, we increased that to 86.2%. And I'll show some data later to show that we actually increased it even more than that following this. But not just that, we were seeing patients faster. So again, you may remember initially we were seeing them within about 6 months, and we brought that down to under 2 months. So again, we're testing more patients and we're getting them results faster. But of course, results are not just about, how what the analytics look like, but what do the patients think about this? So we conducted a study as well. My colleague, Michaela Berkovich-Zadinsky, as part of a research project program for genetic counseling, put together a study studying distress, satisfaction, and decisional regret among patients going through mainstream ovarian cancer genetic testing. And you can see here that this was associated with low levels of distress, 3.97 on a scale from 0 to 45, high levels of satisfaction. So patients overall understood why they were being offered genetic testing. They were given sufficient time to think about why they wanted testing. They understood the implications. They felt that it was really good to have it at the time of an existing oncology appointment rather than coming to see genetics for another appointment. These patients are often very sick and had many appointments. And they overwhelmingly were pleased that they had the genetic test. And low levels of decisional regret. They felt the decision was wise. They did not feel it did them a lot of harm. They would go for the same choice if they had to do it again. They do not regret the choice overwhelmingly, and they feel that it was the right decision. So again, we're testing more patients, we're doing it faster, and patients seem to be satisfied with the results so far. So one of the great things about having a protocol like this is that we're able to really work well between team to team and get a great data set that we can use as quality assurance and also for research purposes. So we were able to actually document all the cases of high-grade serous ovarian cancer at the MUHC. And we did this from August 2017 to October 2022 when we switched over from an out-of-province lab to our internal lab. So in that 5 years of testing, there were 185 new cases of high-grade serous ovarian cancer seen at the MUHC. So of those 185 cases, 4 patients were known to carry a BRCA1 pathogenic variant prior to their cancer diagnosis. So 1 patient had previously declined a preventative surgery and was eventually diagnosed with an ovarian cancer. 2 patients were found to carry a pathogenic variant in BRCA1, given a family history of BRCA1, including 1 patient actually who was part of the other 185. And on preventative surgery were found to have stage 1 ovarian cancer, potentially saving their lives. And 1 patient was diagnosed with ovarian cancer while she was awaiting her predictive genetic testing results. So we moved these out of the sample size here. There were 5 patients who were unable to be tested. 3 of them were deceased prior to testing. 1 patient was lost to follow-up, and 1 patient declined. So we ended up testing 176 patients with high-grade serous ovarian cancer in those 5 years. So again, looking at that, of the 181, 176 underwent testing. So we tested 97.2% of patients with high-grade serous ovarian cancer seen at the MUHC over those 5 years. That's pretty good improvement, over 50%, if I had to say so myself. So looking at the results here, the results really are in line with what we'd expect based on the literature. So about 25%, 24% to be specific, did test positive for a pathogenic variant in a hereditary cancer gene. There were 114 patients who tested negative, 65%, and in 19 patients, 11%, we found a variant of uncertain significance. And as you would expect, just based on the literature, about 2/3 of the cases, 30 out of the 43, were in BRCA1 and BRCA2. Which is really important, obviously, because these patients potentially could benefit from PARP inhibitor therapy. But not just that, we can obviously offer cascade testing to other people in the family. And if, female family members test positive, they can consider screening or risk reduction for breast and ovarian cancer. For the men in the family, consider screening for prostate cancer, pancreas cancer, etc. And of course, we're also seeing a spattering of pathogenic variants in other ovarian cancer genes, RAD51C, RAD51D, BRIP1, PALB2. And we have some unexpected results that may or may not be incidental findings, such as, for example, these 2 patients who were found to have Lynch syndrome, which is not typically thought to be associated with high-grade serous ovarian cancer, but were consistent with the family history and allowed families to start screening for colon cancer if they did test positive. So again, very much in line with the literature would suggest. We're finding a lot of patients who do carry this pathogenic variant, which could have impact on treatment as well as cascade testing in the family. One thing that we found was really important when looking through the data is I looked through the 43 patients who tested positive, and 15 of these patients, so 35%, had a personal or family history of cancer that would have merited genetic investigations prior to their ovarian cancer diagnoses. And these are preventable cases. So while it's great that among the patients with ovarian cancer, we're finding all these pathogenic variants, we're finding the answers, we're able to offer targeted therapies and test the family, every patient who's diagnosed with ovarian cancer who has a BRCA1 or BRCA2 pathogenic variant potentially is basically a failure of a medical system. And we need to do better at identifying these families prior to the cancer occurring, if possible, so they don't even get to the gynae-onc clinic in the first place. So going back to our case here, so we get our 73-year-old patient with high-grade serous ovarian cancer. We offered testing to her as part of our protocol, and sure enough, she tested positive for a pathogenic variant in BRCA2. And this was quite a challenging counseling case because she was not expecting this result to come back positive given the family history. But of course, the next step is to offer testing to other people in the family. And the next step was we offered testing to her daughter and her granddaughter, who both subsequently tested positive. Why is this relevant? Because within 1 year of that diagnosis, both the daughter and the granddaughter were diagnosed with early stage breast cancer that we were able to pick up at early stages. Who knows if that 33-year-old would have been diagnosed if or when. So this obviously went from a family where there was completely non-contributory to picking up early stage cancers in multiple family members, and obviously had a huge impact on the family. It's not always that simple though. That's a great situation, but sometimes we find cases that are much more complicated. So this is a 71-year-old with high-grade serous ovarian cancer, again, a non-contributory family history. And the result came back looking a bit more complicated. So this was the result. It said possibly mosaic pathogenic variant identified in TP53. So you may or may not know that heterozygous pathogenic variants in TP53 are associated with a condition called Li-Fraumeni syndrome, which is associated with a very high risk of cancer, starting as early as infancy, soft tissue and osteosarcomas, early onset breast cancer, brain tumors, leukemia, etc. Not consistent with this family history and not consistent with an isolated ovarian cancer at 71. And we've learned through this case actually, and through research after this, that when we see a mosaic pathogenic variant in TP53, while it could potentially be a mosaic diagnosis of Li-Fraumeni syndrome, many cases are caused by something that was called CHIP. So CHIP stands for clonal hematopoiesis of indeterminate potential, which is a phenomenon that occurs when you have a TP53 variant that occurs in an acquired state. So this is not inherited, and it's not something that occurs very early on in conception. This is an acquired pathogenic variant that can be caused just by the process of aging, by cytotoxic treatments, underlying hematological malignancy or pre-malignancy, circulating tumor cells. It can be quite complicated. So it's really important that when someone gets a result of a mosaic TP53 pathogenic variant, we don't tell them they have Li-Fraumeni syndrome right away. And, because it's very possible they have a mosaic diagnosis, but they need an extensive workup here. So, I can imagine that an oncologist ordering testing that gets this result may be quite confused and not sure what to do with a result like this. And I think this is a really important way to sort of frame the point that, for mainstreaming, it's really important to have a corridor or a pipeline between oncology and genetics to discuss complicated cases like this, to know that what you tell the patient is correct, and to ensure that the patient is seen in genetics as soon as possible, such that we can coordinate the appropriate steps to differentiate between mosaic Li-Fraumeni syndrome and CHIP, which is not associated with an increased cancer risk or for the patient or for family members. So we tend to tell patients when they get a result, physicians when they get a result like this, to say less and refer to genetics, and we'll take care of it from there. So I think given the success of our ovarian cancer mainstreaming protocol and the fact that, as Dr. Foulkes presented the great study, we thought that this was finally time to move on to the bigger challenge, which would be breast oncology-initiated genetic testing, which we've deemed BRIGHT. And we launched this just recently in October 2023. And really, like I said, we wanted to make sure that we had testing being done in-house so that we can simplify this, and also just have a little bit more data from the ovarian side and the breast side through BRIGHT. So in this case, the germline genetic testing is ordered by breast oncologists, be that med-oncs, surgical oncs, or rad-oncs. They're all able to order this. We provide them with training. The idea is that a pre-test counseling discussion should take no longer than 5 minutes. If it takes longer than 5 minutes, refer to genetics for us to take care of the larger discussion. They order the testing by a 31-gene panel here at the MUHC Core Molecular Diagnostic Laboratory. And all results are disclosed by oncologists. So as part of the agreement for ordering the testing, the oncologist is responsible for the results, and they do need to disclose the results to the patients. And in this case, the positives and the VUSs are referred to genetics. I'll put a little asterisk next to the VUSs here because we have had a change in practice since moving the testing to the MUHC. We know that the vast majority of VUSs, or variants of uncertain significance, have no clinical significance, and the vast majority get downgraded to ultimately being likely benign at some points in the future. So we've opted to really try and be very careful with what we report, and only report the variants of uncertain significance that seem like they possibly could have clinical significance in the future. So you'll see that reflected in some of the data later on. So again, a big difference between BRIGHT and JOIGT is that rather than having one single indication for testing, these testing criteria are really aimed at treatment planning. So the idea is, are these patients who could opt for more extensive surgeries if they test positive? Are these patients who could benefit from a PARP inhibitor if they test positive? And I'll go through those criteria in just a minute. And other cases can be referred to genetics. So even if a patient does not meet our mainstreaming criteria, that does not mean that they can't be evaluated. It's just maybe it's better off for them to be evaluated by a genetic counselor or a geneticist. So this is our requisition for genetic testing and our eligibility criteria. So I'll zoom in on what our actual mainstreaming criteria are. So as you can see, there's a checkbox for referring physician specialty. So genetics, surgical oncology, med-onc, gyne-onc, and rad-onc. And any of the above specialties can order testing using one of the above criteria. And anybody who's actually referred testing patients to us in the past will notice that these criteria are actually quite a bit broader than they were historically. And the reason for that is because obviously, testing is cheaper and more accessible now. We were able to expand the criteria. But given that we're not seeing all these patients ourselves, it allowed us to expand the criteria as well. So, testing is eligible for any patient with breast cancer under 50, triple negative breast cancer at any age, breast cancer in a male at any age, contralateral breast cancer with a first primary under age 50, breast cancer in at least one grandparent of Ashkenazi Jewish descent. And this is a big one that we added here that is broad, but we also hope that, it's used judiciously. Breast cancer and testing requested to aid in systemic treatment decisions for PARP inhibitor eligibility. So any patient for whom the oncologist thinks could benefit from PARP inhibitors if they test positive can check off that box. And of course, still our standard high-grade non-mucinous ovarian cancer. And I comment just on here as well that, like I said, if a patient does not meet these criteria, yes, they can't be mainstreamed, but testing still may be made available to them, but they should be referred to genetics for us to assess. A patient with breast cancer at 72 who's got a strong family history of breast cancer, it may be a good idea for them to be seen in the clinic, but maybe they are not the right person in the family to be offering testing. They may be a phenocopy, and there is a condition in the family that they did not inherit. So those patients still should be referred to us in medical genetics. So this is our 31 gene panel, and all of the genes that Dr. Phelps discussed earlier are on this panel, as well as some other genes associated with other common hereditary cancers. And we provide our patients with a pamphlet that we adapted from our ovarian cancer pamphlet as well, that is meant to complement the pre-test discussion from the oncologist, talking about why they're being offered testing, what they can learn, what the possible results are. There is a helpline that sort of links directly to me if they have any questions. And this is really meant to help the oncologist simplify the discussion, because we know that patients are receiving so much information. There's so much to discuss at these appointments. So anything to simplify these discussions, we wanted to put in place. So what we did is we looked at the BRIGHT data from both the MUHC and the JGH. So this is about 5 months of testing. And we've tested 151 patients so far as of the 22nd when I went through the data. And we found 17 positives for a rate of 11%. So this is obviously higher than the 5 to 10% that's typically quoted, but we do have a selected population that is, selected more towards high risk. So that's to be expected. 138 negatives and 1 VUS that we thought to be a bit suspicious. Again, a reminder that we don't report non-suspicious VUSs, so there may be some other VUSs being hidden in this negative result category, but only one that was thought to be clinically relevant. And again, going back to the big three genes, B1, B2, P2, the majority of the pathogenic variants that we found are in those three genes, BRCA1, BRCA2, and PALB2. And we are finding a smattering of other pathogenic variants in other breast cancer genes, such as ATM and RAD51C. MSH6 is a Lynch syndrome gene, and we're still working out whether this could be potentially associated with the breast cancer or not. There was actually one recent case of a patient found to have a TP53 mosaic pathogenic variant, and we are in the process of working up whether she actually is truly a mosaic for Li-Fraumeni syndrome or whether this could be CHIP. And of course, sometimes we find some incidental findings, such as these two MUT1-H heterozygous pathogenic variants. MUT1-H is associated with autosomal recessive disease. You need two pathogenic variants in order to have a predisposition to those cancers or polyps. So we consider those probably incidental findings. So to compare our breast cancer and our ovarian cancer data, I wanted to comment on a couple of things here. So in 5 years of ovarian cancer mainstreaming at the MUHC, we tested 176 patients. In 5 months of testing at the breast cancer for at the JGH and the MUHC, we've tested 151 cases already. So this really shows the dramatic change in scope between ovarian cancer and breast cancer. But also you can see that the difference in the positive rate is quite significant between the two groups as well. Positive rate 24% in ovarian cancer, 11% in breast cancer. But again, as you'd expect, BRCA1 and BRCA2 really do carry the mammoth load of pathogenic variant in these two populations. So what have we learned so far? We've learned, a lot of things. We learned that mainstream genetic testing can increase the number of eligible patients being tested. It can reduce the time between cancer diagnosis and genetic test result receipt. It can impact the treatment. So that can be surgical decision-making on the breast side, PARP inhibitor eligibility. We didn't mention, but clinical trial eligibility is a big thing as well. And I really think it's really important to discuss that this also fosters positive relationships between teams. At a hospital as large as the MUHC, we can really be working in silos, even if we do work together, by referring each other patients. But having collaborative protocols really does benefit both sides. And I feel that, particular work with the Guyana team so far has led to great advances in other studies, working together on the Dovigene project or other studies has really benefited the patients. We do need to do better identifying families with hereditary cancer syndromes before their cancer diagnoses. And that, is involved with education. But also I think that, by moving some of these sort of simple indications outside of the genetics clinic to have them tested elsewhere, hopefully it will free up the medical genetics clinic to use our expertise to focus on the patients that really could use our risk assessment and identify these patients before cancer occurring. One thing that I think is really important here, and we're really learning, is that mainstreaming protocols require buy-in from both sides. So of course, genetics wants mainstreaming because we want patients to be tested faster. We feel terrible that they're sitting on our wait lists. Oncology wants these patients tested because they want these results for treatment planning. But it's really important to recognize that, ordering a genetic test is not just a signature on a paper. An ordering entity does take responsibility for the testing. And that means ensuring that a patient goes for the test, ensuring that they get the result, ensuring that they interpret the result appropriately with the help of medical genetics, of course, disclosing that result to the patient, and ensuring that those patients are referred to medical genetics as indicated. What we don't want to see would be a situation where, a patient develops breast cancer, tests positive for pathogenic variants in BRCA1, the patient is aware or not aware of the result, never makes their way to genetics, and the sister develops ovarian cancer due to that same BRCA1 pathogenic variant and was never tested. Is there a liability question there? It's very possible. So it's really important that ordering a test is not just like I said, a signature, but it's really knowing that you're responsible for ensuring that the patient gets the follow-up needed from these results. And that's not to say that this is to do it alone. Genetics is here to partner up with these oncology clinics to make sure that there is a pipeline in place, and having sort of designated point people on the breast cancer side, the ovarian cancer side, the genetic side is only going to benefit these patients. And I think one thing that's really important to think about is that, these lessons from oncology mainstreaming are transferable to other areas of genetics. So, there's probably many people here in this room right now that work in areas outside of oncology, but they have situations where they follow patients where there's a simple indication for genetic testing and a single test that's indicated. And I would encourage you to think about, rather than just referring these patients to genetics and having them sit on a wait list, why not, call up your local genetic counselor or geneticist and see, hey, is it possible for us to coordinate a simple protocol like this, where we can have a process where we're cutting out the wait times, we're organizing the testing, we're getting the results, and having a corridor of service in place such that a patient tests positive to be seen in medical genetics. So I would definitely encourage you to think about that. In genetics, we really are so open to collaborative protocols, thinking about how we can move things forward, increase accessibility to our patients. So definitely don't hesitate to reach out. So where are we going? I think this is really just the tip of the iceberg right here. And there's pressure from all sides here. So one area that we're definitely getting a lot of pressure, and we really hope to do so, is, like I said, we want to ensure that patients get testing irrespective of postal code or provider. So we want to expand breast cancer mainstreaming outside of the MUHC and the GAGH to other hospitals in the McGill-Rias. So, for example, on the island of Montreal, we receive many referrals from St. Mary's and the Lakeshore. That will be a very logical step. But we also service, let's say, the Outaouais region, so Gatineau or Abitibi-Témiscamingue. I know there's oncologists at both of those sites who are very keen to get this going, and that's definitely on our radar for the next, few months to a year, if possible. And of course, launching mainstreaming for other tumor sites. So the one that's definitely most sort of in the need right now would be metastatic castration-resistant prostate cancer, and we're looking into getting that going at some point. But who's to say we can't mainstream other tumor sites, colon cancer at some point in the future? And of course, thinking about research, we have great data sets here and great collaborative situations. We can really use this for research. And this just gives me an opportunity to shout out Dr. Stephanie Wong, who's a breast surgeon at the Jewish General Hospital. And she received funding through the Rossi Cancer Network to evaluate our BRIGHT protocol. So looking at, how many of these patients are we testing? What other experiences we're testing? Is it having an impact on their follow-up going forward? Are family members being informed of their testing, of the test results and the fact that they can get testing? So I think this is currently going through RAB approval right now, but this is going to be launched at some point soon, such that we can evaluate our own protocol, hopefully publish on this and share our positive experiences with the Canadian community. So really in summary, collaborative protocols between genetics and oncology benefit both services. It's translatable to other areas of medicine. And the take home here is more patients receive better care with less delays and high degrees of satisfaction. And like I said, this would not be done without collaboration from many, many people. I thought about putting individual names on the slide, but it would have just been covered with names. So I'll just say general thank you to the MUHC and JGH medical genetics teams, to the MUHC OptiLab team, to the Gyneo Clinic here, particularly to Dr. Ziggy Zhang, Dr. Lucy Gilbert, Joanne Power, Lori Shabazian, and to the MUHC and JGH breast oncology teams, particularly Dr. Stephanie Wong, for being so supportive of this. And that's all we got, and we'd be happy to take some questions.
Fantastic. Thanks so much. Excellent presentation. Very neat programs. Lots of data to chew on. So we'd encourage you to actually we are actually able to see the chat, so if you want to put your questions in the chat and or raise your hand and speak à vive voix. Our first question from Dr. Gilbert.
Okay, so a comment and a question. The comment is that we are so privileged to have a genetics team. Will Fox unfortunately gets a text from me almost on a daily basis at all times. And Evan, you've been so very responsive. You babysit us, and there's no way we would have done what we have done without you being available. The question is, you said over 6 years, Gyne-Onc, we had so much, but in 5 months, the numbers were almost the same. However, first of all, ovarian cancer is the incidence is much the thing. It was only MUHC, and breast cancer you had MUHC. So the reason I'm asking this question is, Evan, you said about liability, and we are so frightened that there will be a patient who's been identified as a BRCA, and we would have missed. We would not have followed up all the steps. And the only reason I've been not called to court is because of Lori. Lori keeps a record. She follows up. She makes sure we have seen. And I know the medical oncologist. I am frightened that if they didn't have a Lori, there would be a problem, because it comes. We see 20, 21 patients a day. Some of them see 90 patients a day. So there is this, and I'm glad Stephanie has some funds and she's going to, so it's actually auditing what happens after you get a positive result. If it's negative, it doesn't matter.
Maybe I'll just quickly speak to that. I mean, I think it's important to say that the negatives actually do matter. And it's still very important that a patient who tests negative is aware of the results and gets a copy of the report. That can be important for the family. We have the same questions and concerns. Obviously, the load of patients on the breast cancer side is so much larger. And I think the answer is, there's no way to get a second Lori, but if we could get one of the goals from Dr. Wong's funding that she received is to see if we can get someone who can work with us to audit the protocol and ensure that patients are getting the results, that patients who test positive are referred to genetics, and that ultimately is a goal that we have. Because obviously, in a clinic where there's so many patients being seen, there is a risk of patients getting lost to follow-up, and we want to do all that we can to avoid that. And we're open to suggestions, obviously.
Yeah, no, it's a serious worry. I think with the volume of breast cancer patients, unless the medical oncologists and surgical oncologists kind of take this aspect seriously, as you did, Lucy, I do worry, actually, I have to say. I mean, with any new protocol, to a certain extent, you've got to try it, right? But I worry that Evan's sort of hypothetical scenario is not that unlikely, that somebody, if you're getting for getting 151 patients in 5 months and 11% positives, that one of those or two of those women will end up getting into trouble, and then sort of blaming the system. You in a sense, you're testing or counselling. You can't really have both to the same high level. You either do less testing and better counselling, or you do more testing and less counselling. And it's just important. So the question is, where does the balance lie? And to a certain extent, we checked with Jan Jolie at McGill about liability, and it's clearly, I think all doctors know, if you order the test, you're responsible for the result. So I think as long as the ordering physicians realize that, and they can't leave results flying around. And to be honest, they're also not helped by the horrendous IT problems. I mean, as David Huntsman said to me recently, the great thing about faxes these days is only hospitals have fax machines. So if the fax, if you get a fax going missing, you went to a hospital. he has a point. It seems an impossible problem to solve, but the fact that the results have to be faxed from Leora's team faxes them to JGH, and they say, what happened to the fax? Well, I don't know. I can't solve that problem for you. I've had people say to me, "Hey, Will, can you solve this?" I think, great idea. Everybody's got a solution. I've been thinking about this for years. So you're right. It's an important point.
So we've got a couple of questions in the chat. I've got a question as well, and this may be a naive question, but what are the absolute risks of any cancer in BRCA positive first degree relatives? And the second part of the question is, you didn't really sort of describe the family testing as part of these programs, and how rigorous the family testing is, and how far do you push, etc.
Yeah, I can take that one. So for an individual who has a pathogenic variant in BRCA1 or BRCA2, the lifetime risk of breast cancer for both genes is about 70%. That's the risk to about age 80. And the risk start as early as the mid-20s or so. That's when we would start screening for an unaffected individual. For ovarian cancer, it varies between BRCA1 and BRCA2. So for BRCA1, the lifetime risk is around 40%, starting at around age 35 to 40. That's when we would start considering prophylactic surgery. And BRCA2, the risk is more between 15 to 20%, and the age is shifted a little bit more to the right. But there's also important risk for other cancers, particularly for BRCA2. There's an important prostate cancer risk. There's a lesser pancreas cancer risk, but those are the major ones. So anybody who is unaffected and tests positive for one of these genes, could opt for screening or risk reduction on the breast side, risk reduction on the ovarian side, screening for prostate cancer, et cetera. And we do have a protocol that we follow to offer these patients. And anytime we do see a patient who tests positive for pathogenic variant, be it mainstreaming or be it somewhere else, they come into us in genetics. And we say that genetics is the home base for the family. So, the patient really is the family is the patient. So when a patient tests positive, we meet with them, we provide them with counseling, talk to them about their risks, explain the result to them, and we provide them with a letter. Dear members of the Smith family, someone in your family is tested positive for a mutation in BRCA2. Here's what it means. Here's what you can use to ask for an appointment in genetics. And typically, if a patient has family members in Montreal, I say, give my email address out to your family. And within days, I'm getting emails from multiple family members. But we also provide them with documents that they can use to access genetic testing locally. And we go for first-degree relatives typically, siblings and children if they're above age 18. But oftentimes, we can go much, much broader. So even using the example of the patient with ovarian cancer, I've seen probably 10 members of that family already. So it can be quite extensive. And that's through genetics.
And it's interesting, actually, the differing views on how aggressive one should be, which I think is your question.
Mm-hmm. Yeah.
The Australians, for example, they regard it as their duty and right to let everybody know. So if you're diagnosed with cancer, they're going to, and you have a gene mutation, they're going to tell your relatives, whether you like it or not. You have to opt out. A bit like in Australia, you have to vote or you go to jail. Right? So similarly, they have a much more proactive, aggressive role. In Europe, in particular, this would be regarded as completely unacceptable because people have a right to not know things, right? So how do you balance that out? I mean, George Zagopoulos looked at this in pancreas cancer. It's only 14% of eligible relatives actually got tested. Now, it could be because it's pancreas cancer, and you feel pretty miserable about the risk
you being at risk for that. But it's never as good as you think, actually. Cascade testing is never, and BC have a wonderful system where they have a portal and it's BC Cancer Agency. All cases go to one place, so they can follow up all the relatives. But here, I mean, can you imagine? I mean, like I'm saying, the IT issues, we wouldn't know whether some relative went to Quebec City for testing. How would you find out? You'd have to phone the program, and then she may not know, and it gets quite hard to measure. But we obviously hope that these numbers will increase, and it's one of the things we hope to look at in the future.
Yeah. Okay, so on the chat, Dr. Rosenblatt's asking, as you scale up, what's the capacity of the molecular lab? What is the maximum number of breast cancer tests that can be run in the lab?
Yeah, we can scale up. We're gonna use
And how does this compare to the total volume of tests run in the lab? Will the turnaround time increase?
Well, I mean, Laura's actually here, so you can
I think
shout.
we have capacity to scale up. We're getting a new sequencer tomorrow. We can start doing 2 runs per week if we need to.
Yeah.
I mean, the limiting factor is me, but we can figure out a better workflow.
Yeah.
Maybe hire someone.
Yeah, I think that, I mean, we will hit a ceiling at some point, but 48 samples a week. So what David's asking is, how does that compare with other tests in the lab? If you're doing 48 samples a week, how does that?
Cancer's our highest volume test.
Yeah.
Other than CF, but we're the only center in the province doing CFTR testing, and every hospital is doing cancer testing.
Yeah, I think the other difference, of course, is you're doing 31 genes.
Yes.
CFTR is 1 gene.
Yes.
It's around 50% of the volume in genetics. Because if you take anything else, like we are the laboratory doing most genetic cancer panels.
Yes.
If we take out somatic is not even taking that account.
Just the germ. Yeah.
Just the germline. It's around 50% of our germline testing.
At the moment, yeah.
And yes, it's like I say, we have the capacity to increase. We have the resources to do more testing.
Yes.
However, like we have problems, like have people fully trained to do variant interpretation, for example.
Yes.
Having the support from them. We're trying to discuss with the OptiLab directors, open bursaries to train CCMG people.
Yes.
People that are like, this is the problem, and we need to have that help from the hospital. In a way, it's true, this foundation is true, the Department of Oncology of Genetics have the funding. It's not too much money. It's 40,000 a year to have a fellow.
Right.
But it's 2 years training to have people that are fully trained and are able to interpret those variants, as Evan said. It's very important to classify a variant and to clarify a variant correctly. Like give results of variant of unknown significance is super heavy for the patients, for the physicians to explain. Then we need to have people that are highly qualified to do this job. And for that, we really need the support from the hospital.
Clearly a complex situation, but I guess in a way, it's good to have problems that are positive problems. That we're doing things that are benefiting the patients, and that how can we make sure we keep doing it? I think is the message I'm getting.
And one last question before we wrap up from Dr. Jyoti regarding ovarian cancer patients who have variants of unknown significance. Do they have a family history of cancer? Do they have a higher risk of family cancer?
Well, it just depends, to be honest. I mean, it's potentially interesting question.
I mean, I can speak. I mean, we know that 1 in 2 to 1 in 3 Canadians gets cancer, but most cases by chance. So in most cases, you're going to find a family history of cancer. The question is, could this family history be contributory? So if we receive, this is actually a really important point, that when you send in testing, include the family history details, because we use that in our variant interpretation. If you say that, the patient with ovarian cancer also has a sister with ovarian cancer, we may look a little bit more closely at a variant that may be a little bit more iffy. But not all VUSs are the same. We do classify VUSs according to hot or cold. A cold VUS is more likely to be nothing. A hot VUS is more likely to be potentially reclassified as pathogenic in the future. And looking at the family history can clarify that.
Yeah.
Great.
All right.
Yeah, thanks very much again for fantastic rounds. Great discussion.
Thank you very much.
Thank you so much.
Thank you so much.